have this opportunity to spend time with you and to have this time with a real star-studded cast that you'll get to hear from today to talk about the relevance of palliative care research and some very important questions I think that are arising as a result of COVID-19. Our speakers today include Dr. Alex Smith and Dr. Ashwin Kotwal, both who are at UCSF. Dr. Smith is a palliative medicine trained physician and researcher in the Division of Geriatrics, and he spends most of his time doing research on prognosis, mentoring others on all things geriatrics and palliative care, recording GeriPal podcasts, which I'm sure many of you enjoy, and improving the ePrognosis website. Dr. Kotwal is an assistant professor of medicine also in the Division of Geriatrics at the UCSF School of Medicine. He's dually trained in geriatrics and palliative care, and his research focuses on the intersection of geriatrics and palliative care and efforts to understand and improve social connections of older adults at the end of life through clinical practice, health systems, and policy. So we're delighted to have them as our presenters. And in addition, I would be happy to also introduce to you all our panelists that we will also be participating today. Our panelists include Dr. Yael Shanker, who is an associate professor of medicine in the Division of General Internal Medicine and director of the Palliative Care Research Center at the University of Pittsburgh. She's a palliative medicine physician and a health services researcher who is passionate about improving the quality of serious illness care and mentoring a diverse new generation of research scientists. Prasanna Ananth is an assistant professor and pediatric oncologist at the Yale School of Medicine. Her research focuses on evaluating and improving end-of-life care for children with cancer. Dr. Laura Petrillo is a palliative care physician at the Massachusetts General Hospital and an instructor at Harvard Medical School. Her research aims to develop interventions to educate and support adults with advanced cancer undergoing novel therapy. So as you can see, we have an incredible group of folks here to talk with us about this important issue, and I'll turn it over to my colleagues and friends, Dr. Smith and Kotwal.
Thank you so much, Dr. Ritchie. We are thrilled to be here and to have a really incredible group of panelists to share their thoughts on COVID-related research. Today, we will be discussing three primary areas. The first is the impact on existing research, existing palliative care research in our community. We'll next think about how to pivot to COVID-19 research, the pros and cons of doing that, and we'll be discussing some of our own experiences with a research project at UCSF and how we balance those concerns. And then lastly, we'll be thinking about research ideas and collaboration. And our goal here is really to get some ideas from our community and find ways to collaborate that can help to bring palliative care research to the forefront of some of the COVID-19 pandemic issues. The goal for today will be to really foster ideas and share. So we invite our panelists to jump in and interrupt one another. We will not be offended. We also have a chat function, so we will be periodically inviting people in the audience to share their ideas on our topics. We can't promise to read everyone's input, but we'll try to get to most of them. So with that,
please, in the spirit of demonstrating interruption,
yeah,
everybody, I'm going to interrupt and say, just remind people, if you have a question for us or for the panelists, put it in the chat function. Put it in the Q&A box. There's a separate chat function that we're going to use more for technical questions for Naomi. All right, thanks everybody.
Thank you, Alex. And a quick disclaimer here. While this is a webinar on palliative care research during the COVID era, we are putting no pressure on anyone in our community to do research. We understand that this is an extraordinary time, that people have caregiving responsibilities for family members or children. They're juggling multiple responsibilities. We like this recent New Yorker article. If you don't have weights at home, try using canned food or the psychological burden of simply existing in the world. So there's a lot of anxiety on people's minds. And so we want to just be aware of that as we move through. Having said that, let's jump in. So The first is we wanted to think through some of the impact on existing research. COVID-19 has created a number of restrictions on doing research. One of the most striking impacts has been the inability to gather in-person data. And so, Alex, I wondered if you could share your experience with the hearing impairment project at UCSF.
Sure. So I'm working with Meg Wallhagen, who is PI of the National Palliative Care Research Center Pilot and Exploratory Award grant to look at the impact of hearing loss in older adults with serious illness on communication about goals of care and advanced care planning. And the idea was to do qualitative in-person interviews in people's homes. We cannot do that now. And we had literally just gotten off the ground, trained the research assistants who are going to do this work, go out to people's homes in December, and then COVID hit, and we had to completely shift gears. And so now we're shifting gears, and you can imagine for older adults with hearing loss and serious illness, it's harder to recruit participants over the phone. It's harder. You cannot do the hearing assessments that we had planned to do in order to establish the degree of hearing loss over the phone. And it creates a whole host of challenges around, how believable is this data? Are we selecting a subset of people who have mild enough hearing loss that we can actually communicate with them over the phone? And that's just the tip of the iceberg. And I'm sure that many of you out there are facing other challenges with your primary data collection studies. Ashwin is going to go into some others now, but there, if you had an intervention that had to be delivered in person, how are you doing that now that you have to pivot? Can you pivot to making it a video intervention or a telephone intervention? What will you do if you've already collected some data on people who had the in-person intervention and now you have to switch to this video telephone intervention? Or do you just suspend your study? What if you're doing an observational study and you have this big gap because you can't collect measures in person? So many issues that I'm sure we do not have time to address all of them, but I'm going to hand it back to Ashwin, who's going to talk about confounded psychological measures.
Yeah, I think those are really, it's a very striking example. Thinking about hearing impairment, it's not easy to switch over to just doing telephone interviews, obviously. And it also feeds into confounded psychological measurements. We know that the COVID pandemic is impacting people's levels of anxiety, depression, their stress, and so that can confound a lot of the psychological measures in longitudinal studies, for example. There have also been limits on how much time people can devote to research endeavors. Laura, I wonder if you can comment a little bit on how things have been at MGH now that the surge has been approaching.
Yeah, sure. Thank you. So as a palliative care clinician investigator, this is certainly a time where your palliative care services are needed. And so have always kind of balanced clinical practice and research. And I would say since uncertainty is just the overarching theme in everything now, there's been a lot of uncertainty even around kind of what am I going to be doing day to day. And so recently have shifted from doing some outpatient palliative care via telehealth to doing in-person emergency room palliative care consults. And I think as with most of us who are clinician investigators, the sense that kind of clinical responsibilities are and serving our patients is sort of our top priority and first and foremost in this crisis. That has certainly impacted the ability to do research. And I'm really grateful to have a research assistant who keeps things alive, and we're trying to transfer some of our surveys and recruitment over to telephone recruitment, and got some in vivo going on a home subscription. So we've got things kind of on life support, but it's definitely a transition. But I think one thing I've been struck by is how everyone is just ready and happy to serve in clinical capacities right now, and that seems to be the priority.
Thanks so much, Dr. Petrollo. So I think this feeds in, well into some of the next sections where we'll talk about strategies. But before we go into that, we invite the audience members to kind of share some of the challenges that they've been facing and how they've found ways to adjust and cope during this extraordinary time. And Alex, potentially if you see some of these chat responses, maybe you can read some of them out.
Yep, I'll shout them out, and they'll be in the Q&A portion, so in the Q&A window. And while people are typing, maybe we can go ahead and talk about some of these strategies.
Sounds great. So, you know, the most obvious strategy for an inability to gather in-person data is pivoting to telephone interviews. And when that doesn't work and we have to really delay some of the research aims, there have been opportunities to file extensions on existing grants or revise aims. But there have been also creative solutions to the inability to gather in-person data. Some have found ways to add questions to existing research surveys. Yale, you mentioned that some of your mentees have found ways to do this or with existing grants. I wondered if you could share some of those experiences you've had.
Yeah, so I think recognizing that this pandemic is impacting everyone, including our research participants, this has been sort of relatively low-hanging fruit for us to add questions about the pandemic to studies that are already underway. And so, for example, Teresa Hagen-Thomas does work with women with cancer and self-advocacy. She's added questions about COVID to her existing surveys. Another mentee, Haley Bowles, does research on opioid stigma among patients with cancer, and she's added questions about COVID to her in-depth interviews. And we've been able to get, relatively quick IRB approval for these additions, and they're a way of sort of recognizing this experience amongst our research participants, and hopefully learning something.
That's great. Yeah, I think using existing research surveys seems like a very practical way. If you already have the data gathering infrastructure already kind of set up, you can really jump into these research projects and get rapid IRB approval. Thinking about confounded psychological measures, Kara, I know that you've done a lot of studies with caregivers. I was curious if there are ways that you've been successfully dealing with these changes.
Yeah, so a lot of my work focuses on symptom and medication management. And so, of course, this is a very big issue around folks who are concerned that symptoms are due to COVID and rather than pre-existing conditions, and also that caregivers themselves are ill. So it's something where where the caregivers that I'm currently working with are, we are talking about pre and post. For example, before this happened, what was your routine? Now that this is happening, what is your routine? To try to elicit some of the differences in the before and after. Right now I'm working on qualitative interviews, and that's the best spot that I can do. In the future, that's something to certainly consider in the pre-COVID, during COVID, and possibly post-COVID, how these change response to illness and management from the caregiver perspective.
That's great. So really trying to delve into, kind of lean into some of the effects of COVID-19, both by specifically asking about it in surveys, as well as even considering qualitative work. So that seems to have actually create a ton of new research questions as well as you're doing that. We've also been thinking about clinical demands and staffing, how to find ways to pitch in for others. We heard stories, for example, of at Mount Sinai, one of the researchers there, Melissa Aldridge, pitching in and taking a first pass and answering reviews on papers for other researchers who were pulled into clinical demands, which is pretty incredible. But also just finding ways to be compassionate to oneself, to care for oneself as we're thinking about these existing research projects. I wondered if other people on the panel or people in the audience had strategies that we haven't covered.
Maybe I'll just jump in here and read some of the comments from our Q&A. Aaron Kent says, we were able to add some COVID-19 impact questions to our study of family caregivers, which we were about to launch. We were already going to do phone Zoom interviews due to limited budget and the fact that we were focused on rural patients or caregivers. So in that case, it sounds like it wasn't much of the difference here is they had to recruit by phone or email, and they're not sure how that's going to go. But they were kind of set up in that case to do this sort of work, the study itself by phone or Zoom. Gene Kuttner writes, couple comments. We've been converting as much as possible to telephone virtual recruitment, e-consenting, and televirtual data collection. And they've also pivoted to having those who already have clinical contact and therefore are already using PPE to doing some recruiting and data collection. So that makes sense. So you're leveraging, rather than using PPE in order to recruit, these people are already using PPE. They have their face mask for the day or whatnot. They can use that same face mask to recruit some patients. And then says, Gene also says, we've been encouraging mentees and fellows to use the time to write thought pieces and perspectives that they may not otherwise have the time to work on. I've been doing the same thing. It's been challenging because as we talk about in a bit, these journals have just been overwhelmed. As a JAGS rapid COVID editor, I could say that we have had a record number of submissions in the last few months. There's some great material that's being submitted to journals that's just not making it in because they cannot publish that many papers. And then Ishwari Sabia says, frankly, my most effective strategy has been to take my academic expectations of myself down a notch. So give yourself some grace, or several notches. Almost overnight, I became a full-time educator to kids who are now being homeschooled. Yep, just rings true to many of us, while working remotely full-time with clinical and administrative duties. Yeah, absolutely. I'm just going to read a couple more, and then we got to move on to the next topic. Judith Rezick says, we are looking into pivoting from face-to-face advanced care planning conversations to telephone conversations for our study. Also looking into video chat options. Has anyone on the call pivoted intervention modes from face-to-face to telephonic or video chat? Can you share lessons learned or tips? So people could reach out to Judith Rezick directly. Maybe we'll just take a moment here and ask our panelists if any of them have any experience pivoting intervention research from face-to-face to telephonic or video chat.
I don't personally, but I know Danetta Sloan is on the call, I believe. I'm just going to call on her again. I know that she was thinking about modifying her advanced care planning from an in-person to a telephonic. If you're interested in answering that, maybe put something in the chat. I don't know if you can speak audibly.
Yeah, they can't speak audibly, but that's great. Yeah, Danetta Sloan is her last name?
Yep. Yeah.
Yes. So maybe reach out to Danetta. She, as I recall we were on a call with met several of our panelists last week for the, do you correct me if I'm wrong, AHPM Early Investigators SIG. And Danetta shared the story about how she's doing advanced care planning in African American communities. I think it's primarily a faith-based intervention. But she feels at this time that with all of these guides coming out about advanced care planning and how to do it in the era of COVID, she's sending them to these places where she's going to recruit patients, potentially contaminating her study. But she feels like this is the right thing to do. She has to give them the best tools out there to do this, and she'll figure it out later. So we should probably move on, Ashwin, to our next topic.
Hi, can I interrupt you for a second?
Oh yeah, somebody's interrupting. Who's that?
Hi. This is Danetta Sloan. Someone.
Oh, awesome!
So I can talk. Thank you so much. Yes, as a matter of fact, it's been a challenge. Just been a challenge in trying to figure out how my recruitment is going to go. But I am in the process of revising my project so that I can recruit virtually. It just so happens that the two faith-based organizations that I'm working with, they have virtual services and they virtually connect with their congregants and the church leaders who I will be working with. So I'm switching everything around to being able to do some of the training that I'm planning. My project is embedding advanced care planning into the church and developing a faith-based advanced directive using faith language and working with some of the church leaders and trying to develop that. So our meetings are switching to online and to be virtual. And so that part I can do seamlessly. The other recruitment piece and how to recruit the people that I'm currently giving information to, I have no idea of what that's going to look like.
Yeah.
I am recruiting not only the congregants, but I'm recruiting through the church to the African American community, and so I'm just hoping that I'll be able to figure that piece out.
Mm-hmm. Thank you so much, Danetta. And that story really crystallizes so many of the challenges. And, some of these are sort of like ethical conflicts. Like, what do I do in, what is the right thing to do
Yes.
when we have all of these tools coming out about, how to improve advanced care planning? And this time, I think you've made the right decision there to just send them on to the churches. So we got to move on. Thank you so much for sharing that story, Danetta. Ashwin, why don't you take us to the next question? Should I pivot?
Exactly. So this has been on so many people's minds. Should you pivot to COVID research? And, Alex is my primary mentor, and I do research on social isolation. So for me, it was hard not to highly consider pivoting to COVID research to understand the impacts of social distancing on people's social well-being during this crisis. And so in my mind, there are a lot of pros here. It's the biggest topic right now. There's a potential to make a large impact on the community and change the conversation. When I'm sitting at home and working from home, it's hard to feel like you're contributing in a useful way. And so finding a way to add to the research conversation makes it feel like you're helping a little bit. There are massive palliative care research needs. There's a need to bring our voice to what is going on right now. There's a number of funding opportunities, which we'll discuss in a minute, that we can take advantage of. And as Alex mentioned, journals like the Journal of Palliative and Symptom Management, Journal of American Geriatric Society, Annals of Internal Medicine, JAMA, even the New England Journal are all having rapid publication opportunities related to COVID-19 research. So this really seems like, go team moment. Let's get in there. Let's add our voice to the research conversation.
Oh, Ashwin. There are tremendous opportunities to do COVID research, and I hear the pull towards doing what is important in the moment right in front of us. And yet, if you do this, you will be neglecting. It always comes at an opportunity cost, right? What are you not going to do because you're going to do COVID research? And you've built a career, at this early stage. You have a solid foundation in doing research about the social lives of older adults with serious illness. If you move away from that, I'm concerned that you won't be able to build an even stronger foundation for the rest of your early career. There's a lot of uncertainty around this topic, as Laura Petrillo mentioned just a few moments ago. There's uncertainty in terms of how long the epidemic will last. When will we be out of it? How will the consequences linger for a long time or a short time? And then, as we mentioned previously, there are opportunities for pivoting to COVID research, but they're likely to be highly competitive. So, for example, the NIA put out a call for COVID-related supplements. They're worried they're going to get flooded with supplements. So they're really trying to ask people to pre-screen, send your program officer your AIMS page, so they can have an idea of whether it's part of their area of interest. Journals, as I mentioned, are getting flooded. Ken Kavinsky says the JAMA network, they're getting hundreds of viewpoints a day and they're rejecting over 90% of them just because they can't deal with this volume. And they rejected us. Yeah, case in point. So, and then next, this too shall pass, right? This is a temporary phenomena. As a junior researcher, I caution you about building your career about something that is transient, right? In a few years, we will be beyond COVID, and looking back on it, I'm sure will be lessons learned. But this is it's an infection for our lifetimes. It's an event for our lifetimes, but it is also an event and not something that continues over time. So it might be best to leave it for senior researchers who have an established foundation, who don't have to worry about jeopardizing their early, stages of their career to do this. I hate to rain on your parade.
So, Alex, thank you. That gives me a lot to think about. And I think, here's our summary slide of the pros and cons. I think as we were working through this list, we found a way to strike a balance here. We ended up moving forward with a COVID-specific project, but we found ways to make sure that we were setting boundaries on the amount of time I was spending working on that project, that we had clear goals, and that we were able to bring in a large research community at UCSF to work together on this project, so it wasn't focused on just one individual. And I'm curious, Yale, you've been advising a lot of your mentees about this. What have you been telling them about how to focus?
Yeah, so the first thing I've been telling them is it's a challenge to focus on anything right now. And I think just reiterating what you said at the beginning of this call, Ashwin, about taking care of yourself and not necessarily viewing this as a time to sort of get ahead or even be generative for a lot of people. Just sort of keeping your kids from killing each other is a big accomplishment. That said, I guess I also, I don't necessarily view this as a pivot so much, or even necessarily a temporary phenomenon, as kind of a new reality in which palliative care is clearly incredibly important. And we all have to kind of figure out what resonates in terms of our values. And for some people, that's a new research project, a question related to COVID. For some people, that's throwing themselves into clinical work. I think there are all kinds of different ways to sort of approach that. But I guess that's my advice, and that's always my advice, but now more than ever, that feels really important.
Mm-hmm.
Thanks, Yale, for sharing that. We also invite people in the audience to share their thoughts, and I'll turn to other members of our panel. How have you been balancing the pros and cons of pivoting or adjusting to this new reality, as Yale mentioned?
Can I just say a few things about sort of how I've addressed the pandemic? This is Prasna. So my research doesn't really dovetail all that nicely with COVID-related work. And so I've kind of just, I've sort of stuck to projects that involve secondary data analyses or electronic surveys and have sort of adjusted timelines. So I had a survey I was going to roll out to healthcare professionals and bereaved parents a month ago, and I just sort of pushed that off to allow people some time. And that's sort of the way that I've been paying research assistants who haven't necessarily been able to work to their fullest capacity. And so that's where I think we'd like to, during this hour, talk a little bit about ways that we can collaborate, because we have folks who have the capacity to help with data analyses, whether that's qualitative or quantitative research analyses, or survey development, et cetera. And working perhaps with people at other institutions may allow us to utilize those resources fully.
That's great. Yeah. So thinking about collaborations here and finding ways to redirect some of your energies, even if your research interests might not dovetail, you know, easily with COVID-19 related research projects. Are there other thoughts from our panel or thoughts from the audience?
Maybe I'll call attention to another thing in the chat from Jennifer M. I think what was striking from her comment, thinking ahead to when the pandemic winds down and palliative care researchers return to work as usual, thinking about this exact question of whether to prioritize COVID-related research versus thinking about things that we'd previously been thinking about. And just this idea of balancing answering questions that were previously interested, which we still very much need and need to be understood with these kind of COVID questions. So I think just she presents that tension really nicely, that those and that idea that, you know, I think all things are true, like this is a temporary phenomenon and it will have lasting impacts. And so these prior research questions are important. Just wanted to highlight that comment.
Thank you, Laura, for highlighting that comment, and Jennifer for sharing that. Alex, you know, we talked about this a little bit in our own conversations. Journals are getting tons of research submissions related to COVID. Are they still interested in getting research submissions related to, you know, your primary research topics?
Good question. So I can't speak for all journals. I can say that the Journal of the American Geriatric Society, where I'm a deputy editor, we've made a commitment to keep this, to expand the size of the journal. So rather than COVID articles replacing articles that would have otherwise gone into the journal, they are in addition to articles that would otherwise have gone into that otherwise go into the journal. But I don't know to what extent that's the case at other journals. My guess is there probably are some trade-offs in terms of you know, sending your non-COVID related research to journals right now, and that you are at slightly greater risk of rejection if you send it to these journals than you would be if you waited, I don't know when. That's some of the uncertainty problem.
I think a big challenge is and I think felt largely by junior investigators is you know, if we are submitting to some of these journals that are dedicating issues to COVID, that the bandwidth of the editors and of reviewers is less. And so we have to anticipate a longer timeline to review, which I think can be challenging, especially if we want to get papers out in time for grants.
That's a great point, Prasanna. Thoughts from other panelists about submitting non-COVID research at this time?
So this is Kara McDermott. I will say that I have been trying to keep manuscripts going. Number one, because frankly, I need to have data published for my grants. I need to keep myself funded. And there's a tension with that. Now, for me, I study multimorbidity among older adults. So COVID is something that I will incorporate into my research moving forward, but I won't focus on it per se. But especially given what I am hoping to do is continue to try to submit and get published so that I can tee myself up as somebody who can incorporate COVID survivorship issues and how that aligns with multimorbidity in the future. I will say, though, that I'm holding off on submitting to certain journals at this time because I am concerned that I'll have a higher rate of, or a higher chance of being, of having my work not accepted. So I've been revising some of my journal lists to other ones that may not have been my first choice, but may not be hit hard with submissions right now.
I think that's wise. Let me just check the chat one more time. I don't see anything there. Ashwin, why don't we move on to next topic?
Sounds good. So we did want to highlight a few of the research and funding opportunities that are available. Many of you may have seen that the NIH recently released administrative or revision supplements to existing grants, not just through the NIA, but multiple different institutes. within that umbrella. The deadline has been fairly flexible. The last we saw, it was May 1st, 2021. So you're certainly not pressured to have a grant submitted in the next few months. This could be looking at COVID-related research over the next year, for example, or the post-effects of the pandemic. There are also ways of using centers to submit more limited grants. The CTSA centers, for example, or Pepper centers have administrative supplements that can be submitted. We have program officers who are part of the National Institute of Nursing Research, or NINR. Their medical director recently released a statement, which I have a link to, and we can provide to audience members. But we invite them to share some of their thoughts on COVID-related research. There are National Science Foundation rapid response research grant programs, which really aim to look at the effects of natural disasters or other natural events on people's well-being. AHRQ is about to release a new funding resource. They haven't quite released it yet, but they are soliciting notices of intent. The VA has research opportunities through supplements, and they've already started reviewing grants with their first funding announcements expected in May. They're continuing to review grants monthly on a rolling basis. There are a number of local resources. We know that University of California and San Francisco has, for example, provided a number of funding options. And there's foundations. So fastgrants.org has recently come out offering grants ranging from $10,000 to $500,000, although these can be quite competitive. And then we know that there are organizations related to palliative care, PCQN and PCQC, for example, are trying to integrate measures of COVID-19 into their databases. And AHPM has had member surveys to get more rapid information about our palliative care experiences. And we also invite others in the audience to share some of their experiences obtaining funding or other sources that we might be able to look into.
And Ashwin, I'll just note that we have Karen Keel says, it is best if individuals contact their program officer with questions about what funding opportunities are available at NIH. And, so thank you, Karen, for that note.
That's great advice. So let's jump into some of the research ideas that have been circulating amongst our community. So as we have seen, COVID has had the ability to impact every facet of palliative care research. And so Yale, as a director of palliative care research at your institution, I wonder if you could talk a little bit about what you've been seeing.
Yeah, so I mean, I think we've been experiencing many of the things that have been brought up in terms of challenges with ongoing studies, recruitment on hold, having to think about whether to change our interventions to allow them to be telephone or video based. I think the flip side of that is it's been a little bit of an opportunity to rethink things that we've kind of been doing the same way for a long time. And so, for example, we went back to our IRB and found out about all these new ways that we could theoretically recruit remotely that we kind of hadn't thought about in a while. We've also been thinking a lot about sort of priorities going forward. We have a lot of interest in different palliative care delivery models, and so this is sort of a motivation to think more about that. And palliative care via telehealth, is increasingly obviously important and something we're all thinking about. So I think there are some sort of silver linings and opportunities as well. And I'll leave it at that.
Yeah, I just want to riff on that for a moment. It's absolutely true that some of that our telehealth and video health abilities have taken a light years jump over the last couple weeks to months. And those skills will endure over time. Our ability to recruit participants via video and consent them, to engage them in research studies, to do assessments over the phone and through video. We are going to learn so many things from this experience that will endure after the epidemic ends. And some of these will be useful for reaching people who are in rural locations who don't want to come in to do a research study. We may be able to expand the scope of our existing research as a result of some of the lessons and techniques we learned from this epidemic. So there are a number of, as Yale so nicely put it, silver linings here.
Kara, we have heard a little bit about your ability to get a project up and off the ground so quickly. I wondered if you could share your experience with your ongoing study.
So for this is a part of what I'm proposing is actually part of an extension to an existing grant that I have, which was originally funded by the PCRC. It was a pilot award to investigate caregiver burden among bereaved caregivers with multimorbidity. And in talks with folks in February and March, realized that a lot of these same patients are ones that were coming in Seattle who had COVID, and many of them subsequently passed away. So to expand that and to work with bereaved caregivers to talk about how this is different, how COVID has changed caregiving and what the experiences were like with death and bereavement, given that we had to change many of our policies around patient contact, and also how that differs for folks who pass away in nursing homes and elsewhere. So that's the plan. I'm actually working with my mentor, Randy Curtis, and my other mentor, Ruth Engelberg, who I believe is on this call, to expand this and to actually think in terms of collaborating with multiple sites for so that we can get more perspectives and more experiences. Because while Seattle was the first to experience this, and there may be commonalities, there also may be differences depending on where you live. So if folks are interested in bereaved caregiving in the era of COVID, please let me know.
That's great. And that's really fantastic that you've been able to collaborate with other sites. How has that experience been, finding and building connections?
That's getting off the ground. And that's something that really, I have to thank Randy and Ruth for being folks who are very collaborative and have built a network of folks that I can then speak with about these potential collaborations. So for right now, that's in the planning stages. We haven't expanded. So I do want to offer to folks that if you are interested to please talk to me.
That's wonderful. Great. And I can share a little bit about my study here at UCSF, which I've been working with Alex to help develop and get off the ground. We've been really interested in understanding the unintended consequences of social distancing for the well-being of older adults in San Francisco. And so we've been trying to get a project off the ground to conduct telephone surveys of vulnerable older adults around the city. And it's gone smoothly in some areas, for example, getting IRB approval, expedited, and finding people to collaborate with. But it's been really hard in other ways as clinical responsibilities have ramped up, or just finding ways to interview people who already have so much on their mind and have a hard time participating in these types of surveys. We've been able to harness a ton of enthusiasm from different members of our community to conduct the surveys. So medical students and pharmacy students who had many of their classes canceled, who are in their first or second years of the school, actually proactively reached out to us to volunteer to administer the surveys. So we were able to really utilize some of that enthusiasm to recruit. So it's been a good study. We're hopeful that we'll have valuable data. And if at the end of the day we don't, we're at least taking comfort in the fact that it's been helpful to reach out to older adults in our community and show that there's kind of people to listen to their stories as they're going through this. We've also been brainstorming a lot as a community. Laura mentioned the AHPM Special Interest Group call that was had last week, where we've discussed a number of topics. So caregivers and bereavement. Access to caregiving has changed substantially over the last few weeks. Visitor policies in the hospital have impacted how people are processing some of the challenges of critical illness and also grieving. So the inability to go through some of our typical grieving rituals because of a lack of in-person contact, all has affected us substantially and are ripe areas for research.
Mm-hmm.
The social well-being
Yeah,
and
just to interject for a moment.
Yeah.
You know, hearing stories of, and some of us are familiar with these, or have experience with these patients. You know, patients dying in the hospital alone, not having seen their loved one for days to weeks, and the loved one not being able to get in to see them because of COVID restrictions on visitors, which are sometimes relaxed when patients are dying, but often are not. You know, what are the psychological outcomes for those caregivers in terms of bereavement? So much to unpack here.
Thanks, Alex. And I think again, this has really impacted all areas of palliative care research. Alex mentioned palliative care delivery models that we've jumped forward light years, it seems, in our ability to conduct telehealth consults or even consults across a great distance to people who are living in rural communities or who don't have access to palliative care normally. Thinking about patient outcomes, we've seen a lot of decreases in resource utilization in the ED among people who would normally be there, people who are missing, who might have strokes or heart attacks. What are some of the palliative care symptoms that we're not seeing right now that might be neglected at home, like untreated pain, for example? Specific patient populations that are potentially experiencing COVID-19 in a different way, people with advanced lung disease or ALS, for example. The survivorship of having COVID-19, is there persistent trauma or persistent symptoms? Advanced care planning, where we've already seen a number of very impactful perspective pieces and discussions. And health systems. So how has this impacted our access to hospice? How's this affecting palliative care delivery in nursing homes? I think the number of research topics is, hard to count, but we are curious, if there are other ideas that you'd like to share with the community.
And if you could please share those in the question and answer section, not the chat function, that'd be great. I'll just note that Claire Richards had a couple of comments here. One is, because of climate change and power outages due to extreme weather events, we need to also think about energy equity. Not exactly sure what that means. Maybe this is another public health emergency that comes down the road. And maybe it is also a comment about access to technology, for example. And then important to note that, caregivers are not being allowed to visit those in the hospital due to lack of PPE in regards to telehealth. I think that, yeah, okay. Maybe we'll move on. If people are typing, we'll try and read some of those comments there. Aaron Kent says, achieving health equity is a fundamental challenge at all times, but brought into higher relief right now. Absolutely true. I've heard Laura and Christine Ritchie, you're in Massachusetts, and I've heard that, African Americans make up something like 15% of the state, but represent something like 40% of the deaths. I think, it's hit the African American Latino population particularly hard. I'm working with Eric Wadera, and I are doing, and many others are doing remote palliative care consults at New York and New York Presbyterian. And I would say 2/3 of them we work with a Spanish-speaking interpreter. The burden of death and morbidity has fallen far more heavily on minority communities. And so thinking about through what are the implications of that? How did this come to pass? Was any of this due to rationing decisions, or is this due to pre-existing disparities in access to health and in health equity issues that have been present historically and also throughout people's lives? There's just so much to unpack there as well. So great comment, Aaron Kent. Claire, okay. Yes. Claire Richards also says the second comment was the clarification. Sorry, I'm getting lost in that one. But maybe we'll go back to the slides while people are typing. Or if any of the panelists have anything to add to what we've talked about in terms of topics. I know we've got 5 minutes left and we're nearing the end here, or on ways to collaborate.
Well, I'll jump in about collaboration. So as has been sort of alluded to, we have a special interest group or forum within AHPM for early investigators, but we're open to kind of the perspectives of all. And also think having multiple kind of sources of this coming together would be helpful too. But within our group of early palliative care investigators, we've been thinking about ways we could help each other. This has always historically been a community of incredible people who come together, and particularly I think as junior investigators we all have experienced the generosity of senior investigators with mentorship and resource support. And so this is just a time where some of us will have research assistant support, or perhaps time or methods expertise to lend each other, or be in need of those things. And so we had discussed sort of having a living document where people could both find each other for collaboration, like Kara spoke about, finding people who have similar research topic ideas to increase the size and scope of research studies, and then also finding ways to support each other in getting our existing research across the finish line. So I love the spirit of generosity and collaboration. And if you're a member of AHPM and want to join our group, we'd love to have you. But also wonder if there are ways within PCRC similar kind of collaboration could be fostered.
It's great. Just Danetta's commenting here. Caregivers not able to be with loved ones when they die. Cultural rituals not taking place. Yes. What is the impact? Is there moral injury? Yeah, those are terrific questions. Yale, it looked like you were going to jump in a moment ago.
Oh, I was just going to reflect on the impact on our field and hope that we can find ways to think about that and study that. It's been amazing to see so many of you in the news and palliative care being talked about in so many places, and a sense, from my perspective, of collaboration with other services, and so we're all in this together. So I just love that to be something that we continue talking about and reflecting on throughout this.
Thank you. And that Jennifer M., building on that comment, says, wondering if the pandemic has somehow been a catalyst for integrating palliative care into practice, thinking of it as an implementation question. Absolutely, yes. So, again, at Columbia, where we're doing these remote palliative care consults, they were a consult service only. They did not have a service where they took care of patients primarily, and they were first call. They were not in the emergency department. They're not in the ICU. Now they have a palliative care service where they're first call, and it's been expanding rapidly. They had 8 beds, and they When I was on for 1 3-hour stretch, they got 6 referrals and they only had 2 beds. So they expanded to 14. Apparently they're going to get some more beds in like a field hospital under a tent. The ED called. They wanted them in the emergency department. They now have somebody stationed in the emergency department all the time, having goals of care conversations. Same thing with the ICU. We did a podcast with folks at the Brigham last week. They said the same thing. Laura, I know that you worked last week with Christine Ritchie in the emergency department at MGH. So absolutely, it's been a catalyst for integrating palliative care into practice. We have been in high demand. And as Yale pointed out, there's so many questions here about how could we study this? How could we study what are the implications for this, rapid change and growth in palliative care and our reach? Just descriptive. We've gone from doing this to doing that as a low level, and then what happens after COVID? We built these relationships in the emergency department, in the ICU. Do we stay after the epidemic ends? Has this led to a sea change in perception of palliative care from other clinicians, from caregivers, providers, from the people who are calling on the phone, engaging them in advanced care planning? I just want to read a few more comments because we have a bunch of them pouring in here. We have Krista Harrison, who says, another idea for research, the impact of COVID on hospice, both in terms of impact on how clinicians care in person in varied settings for COVID positive and not COVID positive patients, and impact on business practices. Huge issue. We did a podcast with somebody from Bluegrass Hospice and Kai Romero from Hospice by the Bay recently. They're, I would say, marginally impacted, but what about those hospices in New York, in Seattle, in areas that are heavily impacted at this time? Who's taking COVID patients? Who's not taking COVID patients? How are they making these decisions? What is it like to care for these people? And what lessons can we learn from this epidemic that will endure after the epidemic ends? So many important questions there. Shirley Otis Green says, research on the impact of healthcare professionals. I think you may mean on healthcare professionals. Moral injury, moral distress, implications on leaving the field, burnout, compassion fatigue, etc. Also incorporating of palliative cares into generalist practice. So many important questions there. We've talked, I've talked to many people throughout the country who feel, just last week we had our podcast with Ricky Leiter from Brigham saying, I have to debrief about this all the time. These consults are hard, and they're pushing me to, am I doing the right thing here? I'm always asking myself. And so many people in palliative care are coming to me, we're hearing from them saying, I try not to have an agenda generally when I go into palliative care consults, and yet I have an agenda here, right? I know my hospital is running out of ICU beds. I know we're running out of ventilators. I know the outcomes are poor. I am pushing these conversations at warp speed in a way I never would have done before. The cadence has changed completely. What is the impact of those decisions in that practice and seeing more death than we've ever seen in our lives, even in palliative care, have on us as healthcare professionals? Those are terrific points.
On our field, I think really important to think about, and on our field, what it means to have that sense of feeling like we have an agenda or have others have expectation of us having an agenda. I think that's a critical point.
Mm-hmm. And I see we're out of time. We gotta wrap it up.
So we will try to share many of these ideas, and we'll be in discussion with PCRC to find ways to facilitate ongoing discussions, because many of us are thinking the same things. And I think this is a right time to have multi-site studies, or at least collaborations to think through surveys and questionnaires together. We have a number of additional resources that we'll be sharing with everyone after our presentation. There are shared interview items for vulnerable populations. There's a collection of palliative care research articles on COVID. As Laura mentioned, a living document on palliative care research ideas. Just recently published best practices for measuring some of these impacts during epidemics. And even for people who are mentors, who have mentees, NIH virtual activities for trainees for people who continue to need that research training. So thank you, everyone. I will defer to Naomi to discuss the next webinar, but we're so grateful that you all were able to join, and we welcome continued thoughts and feedback.
And thank you so much to our panelists. Really appreciate your input and involvement in putting this together. Very helpful. Thank you so much.
Thank you, guys.
Thanks for
Naomi?
Thank you.
Yeah.
And thank you so much, Alex and Ashwin, for speaking today and for having such a fantastic panel. And thank you to everyone who's joined us. If all of our attendees do go to our website, we have 2 more webinars that are posted for the near future. In fact, we have Dr. Laura Hansen speaking on So You Want to Design a Clinical Trial to Help People with Dementia and Their Caregivers. She'll tell you, here's where to start. And then at the end of May, we have Doctors Karen Kale and Lynn Adams to talk about the NIH grant process, submission to council. And that is a follow-up on the 2-part series. Please check out our PCRC website to catch part 1 if you missed that. We'll also be sending out an evaluation where we gather other topics that you might be interested in learning about. So please take a minute to fill that out. Thank you again to our speakers and our panel, and for all of our attendees for attending. The PCRC is here to support you with consultations, and we look forward to hearing from you. Take care, everybody.